Okay, so we have this little girl who on physical examination holds her hand, her right arm close to her body with forearm pronated. No swelling or focal tenderness in her upper extremities elicited, but she winces when supination of her arm is attempted. So what is the best next step for this patient? So we do x-ray if there is a history of a trauma or fall and there is a focal tenderness and we suspect fracture. That's what we do. MRI we do when there is ligament or tendon disorder like sprain, partial tear, cartilage lesion, occult fracture, osteomyelitis. That's when we do. Okay, and this can be done by outpatient emergency provider, so we don't need to refer her to anyone. So that's why the other options are not true. This one, a 12-month-old boy who his older sister was diagnosed with infantile type polycystic kidney disease and underwent kidney transplantation months ago, 2 months ago. So she is receiving immunosuppressive therapy. Patient is scheduled to receive varicella vaccine today. What is the best next step for this patient? Yeah, so this patient we observed for a rash, and the idea, the contraindication for varicella anaphylaxis is that anaphylaxis to neomycin, this is contraindication to varicella, anaphylaxis to gelatin, pregnancy, and immunodeficient state, a congenital immunodeficiency, long-term immunosuppressive therapy, hematologic or solid tumors, and severe HIV infection. All of those are contraindications for VZV. There. Okay, this patient who comes to the office for follow-up after non-STEMI MI and normal morning erection. What is best next step for this patient? So this patient we provide psychological counseling. So routine sexual activities associated with the physical exertion approximately 3 to 4 metabolic equivalent. So which is the same to brisk walking or ascending 2 flights of stairs. So this patient has we can't like prevent him from that. So diabetes increases risk for for choice B, increases risk for erectile dysfunction, but this patient has a morning normal erection, so this is not the case. And sildenafil, this choice C, we use it for someone who have a cardiovascular risk for morning erectile dysfunction, vascular erectile dysfunction, but not in this patient. And beta blocker carvedilol can increase risk for erectile dysfunction and could be contributing, but it's important for patients who just had an MI, and it's not good to discontinue that after myocardial infarction, and especially when the erectile is psychological, not something that's physiological. Okay, period. So yeah, the other causes of erectile dysfunction is that hypertension, smoking, bruit, decreased pulses, and due to underlying disorder, TSH, SSRI, antiandrogen, antihypertensive, loss of pupocavernous reflex. It could be that loss of libido, gynecomastia, testicular atrophy that can cause that. Yeah. So this 14-year-old girl, this is another case, 14-year-old girl who is smoking and her mom is smoking. So how to help her? This is not that an important of a comparison, but just tell her like an effort to quit yourself have a positive influence on your daughter smoking. So it's not that big of a comparison in this case. So we just go through it quickly. Yeah, we'll focus on the question that have a good comparison, like in this one. Okay, so this patient have anemia. Okay, it comes for easy fatigability. MCV and MHCV all decreased. So what do you do? What is best next step in management for this patient? Yeah, so for the direct Combs test, they will have normocytic, normochromic, so the MCV will be normal. So this is not the case. Fecal occult blood is the right one. Hemoglobin electrophoresis for thalassemia. Thalassemia, they have the MCV decreased, but the red cell distribution would be normal. So that's the difference. And thalassemia earlier in life, it's not in a 55-year-old guy. Okay, so that's the thing. And rheumatoid factor, they have the ferritin increased. This serum ferritin is normal, this patient. So if it was ferritin, then I'm suspecting that. B12 and folate, they have macrocytic increased MCV, so that's the difference. Yeah, so this is fecal occult blood. Excellent. Okay, good job. Nice. Okay, this 65-year-old Caucasian female present to the office with a history of dry mouth. She says that she feels dry all day and she has to drink water. She also complains of sandy sensation in her eyes. So what do you think is causing her problem? What's the best next step? Okay, yeah, so this patient, we do the raw antibodies rheumatoid. So salivary gland biopsy is the gold standard for Sjogren's syndrome. It's not the first line, it's after that we do that. It's a gold standard. Okay, salivary gland scintigraphy imaging may be helpful to assess the structure of the gland. Okay, and but the first thing we test for antibodies, and low dose steroid are not appropriate at this time. And this patient needs a diagnosis. We can't reassure, just reassure. Okay.
She reports sudden inability to move her neck to the left and says there were no preceding symptoms such as numbness, tingling, weakness, or anxiety. Best next step. What? Calcium, dantrolene, diphenhydramine, magnesium, or clonidine.
So this is it's the diphenhydramine. So intravenous calcium gluconate, we use it when there is hypocalcemia. Hypocalcemia causes tetany. Okay, and perioral and paresthesia. That's it. They have nose so this is the thing, the different. This patient has sudden inability to move. This is dystonia, different. Dantrolene, what we use that for neuroleptic malignant syndrome. When they have altered mental status, fever, rigidity, that's the difference. Intravenous magnesium used to treat torso de pointe, not this sudden inability, dystonia. Hypertension used to treat, clonidine used to treat hypertension. So this patient have a little bit of a hypertension, but it could be due to dystonia and stress that he's having from dystonia. So first, the most urgent concern now is the diphenhydramine for the focal dystonia. So that's the main.
What is giving her dystonia from just hypokalemia?
Yeah, it could be. So it could be like multiple. This patient is taking antipsychotic. So that's one of the side effects of antipsychotics, so develop the sudden dystonia. But what I want you guys to know is that this sudden inability to move the neck, that's a dystonia. So that's the feature, the thing that I want you guys to know. Okay, this patient is a 26-year-old female who presented to the office with a greenish vaginal discharge. Vulvar pruritus started several days ago. Pelvic exam shows non-tender anteverted uterus, no adnexal mass. Speculum examination shows punctate hemorrhage. That's the most important thing everyone needs to know. Okay. Watch. So what's the best next step for this patient, and why not the other options? Yeah, so this patient, we give the oral metronidazole and express and discard the breast for 24 hours because it interacts with the breast. So they don't use metronidazole while breastfeeding, and this is trichomonas. So this patient, we don't give doxycycline. Doxycycline is a treatment for chlamydia trachomatis, which causes mucopurulent discharge, friable cervix. That's how they describe it in the question stem. Okay, and doxycycline is not recommended during breastfeeding as it's excreted in the milk and causes tooth discoloration and enamel hyperplasia in the infant. so it's never recommended. Not oral fluconazole, because this treats vulvovaginal pruritus and erythema due to candida, which are present with thick, white, clumpy discharge. That's the thick, that's a keyword. Thick, remember that. Candida, thick. Fluconazole is excreted in the breast milk. However, breastfeeding can be continued, and there is no problem with fluconazole with the breastfeeding. Okay? Metronidazole, if we replace it with formula, we don't need that. We just need one time, only for 24 hours. That's the difference. Okay, so vaginal metronidazole is not that effective like the oral one, so that's why we don't use it, because the cure rate is low, less than 50% than the oral therapy. Okay, so that's why, not the other options. Okay, because metronidazole can pass through the fetus and can kill some of the good bacteria in the baby and causes increased risk for loose stool and candidiasis in exposed infant. So we don't want that. So that's why we do that. Okay. So
Urinary urgency, hesitancy, nocturia, and weak urinary stream. His PSA level is elevated, and he explained the option of transurethral resection of the prostate. Complications.
He's 63-year-old African American, hesitancy, urgency, and he had the transurethral resection. So what are the complications of this procedure? That's what they want to know. So that's the trick for this question. All of them are true. All of them complication. Can cause stricture, can cause urinary incontinence, can cause erectile dysfunction, can cause UTI. But the most common one is retrograde ejaculation. Okay, all of them complications of erectile dysfunction, but the most common is retrograde ejaculation. That's how the questions of the that's the tricky. The other day I had a question. It was very tricky. They present a guy with obstructive sleep apnea, obesity. He's obese. Okay, so he's more than 34. He has tongue scalloping, and he has neck circumference 17.7. So they said, which one is most strongly associated with that? And they put everything. They put obesity. They put the tongue abnormalities. They put everything, and they put neck circumference. And the answer was neck circumference. And the reason is that because it's more associated. That's why. Yeah. Another tricky case.
Obstructive?
Huh?
It's more associated with obstructive sleep apnea. Is that what the answer was?
Yeah, neck circumference. Another question was tricky. Is that patient who's on bipolar and she's taking lithium, okay? And she developed thirsty and polyuria and stuff like that. Why? What's your diagnosis?
SIADH.
No. So what the answer was diabetes due to second generation antipsychotic.
Diabetes insipidus?
No, not diabetes insipidus. It's
just diabetes.
Just diabetes due to second generation antipsychotic that she's taking. Clozapine. So the trick was they give HbA1c was 7. That's the only trick that so it was very tricky question too. It's interesting though. They play with it like this. Okay, so this patient who's HIV positive, 27-year-old HIV positive, comes to the emergency department with shortness of breath, dry cough, right-sided chest pain since yesterday. There's multiple needle track and painful subcutaneous mass in the right antecubital area. Okay, that's a good one. Neck pains are flat. When the patient semi-recumbent, there is a 2 out of 6 systolic murmur heard at the external border. The liver is palpated 1 cm below the costal margin and is non-tender. Chest X-rays, nodular opacity in both lungs, including subpleural opacities. What's your diagnosis? What's best next step to diagnose this patient? Yeah, so that's the key for this question. They told you that he have multiple needle and painful subcutaneous mass in the right antecubital area, and that's the biggest clue, is that reveal nodular opacity in both lungs, including subpleural opacities in the right. There are multiple subpleural opacities. That means infarct, multiple infarct. So what she's having is and she has murmur in the fever. This is infective endocarditis. So the tricuspid valve starts shearing some of the thrombus and goes to the lung, and like imagine, so one pulmonary emboli can destroy you. This patient have multiple pulmonary emboli, like start shooting to the lung and obstructing vessel, causing infarct. So this is infective endocarditis. It's a bronchoalveolar lavage. This present only when there is, so the bronchoalveolar lavage present only CD4 less than 200, and they have a 3-week history of low-grade fever, non-productive cough. And another big clue is that chest X-ray reveal interstitial infiltrate rather than nodular opacities. So that's the big difference, and it's subacute presentation. It's not as acute as this one. So CT angiography for what? For pulmonary embolism. This patient, so if it was pulmonary embolism, they have single infarct, not multiple infarct like in this patient. Okay, and they don't have high-grade fever. They have fever, can have fever, but not high-grade like in this patient. And the other thing, they have also sudden pleuritic chest pain. That's the difference. Okay, so it's transthoracic echo is the correct answer. It's not urinary Legionella because Legionella present with what? Lung and GI symptoms. Can cause fever and characterized by relative bradycardia, they call it, high fever, low heart rate. And gastrointestinal symptoms, vomiting, diarrhea, cough and a fever. That's the features of Legionella. So this patient is infective endocarditis. They call it septic emboli. Okay.
Boy is brought to clinic by his adoptive parents due to worsening cough. He has productive cough with yellow-green sputum since he was adopted from a developing country. X-ray is okay, so he's had a productive cough since he was adopted. Okay. Auscultation of the lungs reveals scattered bilateral bronchi and wheezes. Chest X-ray shows hyperinflation with increased bronchovascular markings throughout and several parallel linear opacities in the bilateral upper lobe parenchyma. That's next step. Does the age matter here?
A 10-year-old boy. So
okay.
tell me, what's your diagnosis and why not the other ones?
It's some sort of, based on the answer choices, probably some sort of autoimmune deficiency, right? So, let's see. Quantitative serum immunoglobulin, that's common variable immunodeficiency, I think?
Okay, yeah, so this patient is a 10-year-old who presented with a worsening cough and yellow-green sputum and auscultation of the lung bilateral bronchi, chest X-ray hyperinflation, bronchoalveolar marking throughout several linear opacities, and I can add also he has constipation too. That's another good clue to have. So this is the sweat chloride test, the right answer. So it's not adenosine deaminase, like Mina said. It's in SCID. SCID they have present in early age, like few months of life, and they associated with infectious diarrhea rather than constipation, like in this patient. This is one thing. Another thing is that they have recurrent bacterial, fungal, and viral infections. They have recurrent like EBV, cytomegalovirus, herpes, pneumocystis jirovecii, candida. Those are the stuff that they have. So it's not dihydrorhodamine oxidation test because this diagnostic for chronic granulomatous disease, which is X-linked immune disorder characterized by severe fungal and bacterial infection and skin infection. So the way they presented, they told you had a history of infection with Serratia, another infection with Aspergillus niger or something, another infection with Staph aureus. So they have infections, recurrent infections with catalase positive bacteria, and they have recurrent subcutaneous abscesses. That's how they presented. They had a lot of questions like this on step 2 CK for some reason. They had like around 4 or 5 around that. dihydroxyurea. Quantitative immunoglobulin assay, which is common variable immunodeficiency. They have recurrent diarrhea and lung infections. This patient have constipation and did not have diarrhea, so it's likely to be sweat chloride test. Like it's serious, like literally cystic fibrosis, crazy condition. Like common variable immunodeficiency, that's okay. You give him immunoglobulin, he'll be fine. SCID, they die. CGD is less severe. HIV, there are medications for it. But this cystic fibrosis, they don't die and they stay. Like they will be tortured their whole life. Till 30, I think they die, 40, something like that. So it's very tough. They have failure to thrive, malabsorption. They need enzyme replacement, and they need to have like this DNAs and those mucolytic agent. They have to stay on them for life. And there's not much, like medicine don't do well on this condition. Like they can't do much because it's a thick mucus and a low obstruction, a very good environment for the bacteria to grow. So they keep having these recurrent infections. Yeah, so it's tough. Imagine, like, if we have a flu, we'll be pissed. Like, imagine if they have recurrent pneumonia, recurrent like CMV. These are big infections. It's a very tough life. Like they are there like for us to learn from them and be grateful for what we have. I think that's why. Okay, so that's the idea of this question. Okay, now we're gonna go to the next one. Okay, this guy is a 70-year-old who comes to the emergency department due to redness and pain in his right leg. So what do you think is the diagnosis? And at the time of admission he was calm, and then after that he became irritable, restless, unable to sleep, tremulous, diaphoretic, argumentative with the nurse. Okay, so temperature is high, like it's around 99, blood pressure is 160, increased. Okay, pulse is 100, this one is 160, this one 100, and respiration is 18. So what's best next step? And oxygen is 93. Yeah, exactly. This one we give him the razepam because it's most likely it's alcohol withdrawal, because he was admitted for cellulitis and then he developed this delirium, which is agitation, diaphoresis, tremulousness, increased pulse, increased blood pressure, autonomic instability. Those are all symptoms of withdrawal, alcohol withdrawal. So we give him lorazepam. Haloperidol, we don't use it when the cause is due to the alcohol withdrawal. That's the most important thing. Carbamazepine is not used for alcohol withdrawal. I'm sorry, what? So this patient have alcohol withdrawal. So there are these complications of alcohol, like in the first day, they will have they call it mild withdrawal. They have anxiety, tremor, diaphoresis, palpitation, GI, upset, but the orientation is fine. But in the second day, they are at risk of two things: either seizure or alcoholic hallucinosis. Seizure, obviously known, tonic-clonic seizure, contraction. That's how they describe it. Tonic-clonic, stiffness of the extremities, jerking movement. Alcoholic hallucinosis, they can have visual, auditory, or tactile hallucinations. And after the second day, after 48 hours, they are at risk of delirium. Delirium, they have confusion, agitation, tachycardia, hypertension, diaphoresis, hallucinations. So you see the symptoms are almost similar. The main thing to differentiate them is the timing. So watch out for the timing. That's an important one. Okay, so this patient is just we use lorazepam. It's a safer medication. Okay, and short acting. So for example, chlorodiazepam is a benzodiazepine, but this one is longer acting. Okay, so that's why we don't use it. Okay, and then we adjunct management. We give him IV fluid, monitor vital signs. We give him thiamine and nutritional support. That's the main management for this patient. Okay.
She says that he's been acting strangely for the past few months, spending less time with his friends, more time on the computer. What's next up? Symptoms are likely related to drug use. Should resolve as no. Acute onset, presence of delusions are good prognostic factors. He should respond well to treatment. This likely represents the onset of major psych illness given your son's. How old is he? Given your son's age.
19.
Okay. Family history of schizo. There's a family history of schizo. I don't know. The son likely had schizophrenic disorders, which brought him in now as early medication treatment. He's been having it for the past months. So
he's using drugs.
Oh, he is.
Yeah. So tell him like he's showing signs of psychotic illness. So this is but even though he's using drugs, but his symptoms are most likely due to schizophrenia.
How many months?
Hmm?
How many months? What's the time frame?
Yeah, so that's the idea of this question is that he's exhibiting symptoms of schizophrenia, but he's using a drug. So we tell her like, let's first is to see what extent his symptom resolve when he stops using drugs. So that's the best answer. So your son, huh?
The question there's like.
Yeah, it's missing. Yeah, it's missing some of the information. But the idea of this question is that just tell her your son is showing symptoms of psychotic illness. First step to see what extent resolve when he stops using drugs. Yeah. So these types of questions, there is not much great comparison that we can learn from. That's the main thing. The only thing that I want you guys to know is that the good prognostic factors for this patient. What are the good prognostic factor for schizophrenia? Do you guys know?
The positive symptoms, right? The delusions, hallucination, or that's like the good stuff.
Exactly, yeah, those are good stuff. But that means they likely respond to antipsychotic. But if they have withdrawal, loss of motivation, it's very tough. Like very tough that they respond to antipsychotics. Yeah. So this question is not that great of a comparison. So we just go through it quickly, and then we'll focus on the one that has good comparison. Okay, this patient. So 24-year-old female. Physical examination mildly enlarged, smooth non-tender thyroid gland, and the test performed last week, TSH of 0.7 and T4 is 15. So 0.7 is very low and T of 15 is high. It's normal 4 to 12. Okay, so what's treatment for this patient? And she's taking methimazole and she's about to be pregnant. Yeah, so you're right. So change it to PTU because if she continued taking methimazole and she became pregnant, so on the first can increase risk for what? It's, like teratogenic conditions. Most likely there's one called cutis aplasia. That's a big one with methimazole. So we don't know if she's planning to be pregnant. So we change it to PTU until after she passes the first trimester. After that, we can switch back to methimazole. So methimazole is good in the second and third trimester, but not in the first trimester. So if patient is trying to be pregnant or in the first trimester, we change it to PTU. So that's a trick part of the question. Beta blocker, we use them before thionamide or some just to control the sympathetic activity symptoms with the hyperthyroidism. That's the main difference. Thyroidectomy considered for pregnant patients if they have severe symptoms despite thianomide. If they're taking thianomide and then they still have hyperthyroid symptoms, then we do that. Radioactive iodine uptake is absolute contraindication during pregnancy because it destroys the fetal thyroid too, not just the mom. So that's a big no-no. Okay, so that's the idea of thianomide is the treatment of choice for hyperthyroid during pregnancy, and PTU in the first trimester, and methimazole in the second and third trimester. Because in the PTU, so this is another trick. PTU, if it's used in the second and third trimester, increase risk for hepatotoxicity, so we don't want to use it for too long. Okay? So that's an important, this one. This is 29-year-old female. Okay. So, who had this uncomplicated vaginal delivery 10 months ago. The patient underwent induction of labor at 39 weeks and gestation for insulin-controlled diabetes, gestational diabetes, okay? So that's the thing. Blood glucose level 1 hour prior to delivery was 112, 118, I mean, sorry. So which of the following right now in postpartum period, what do you do right now? She's postpartum, she had history of gestational diabetes. That's all what you need to know. Right now, what do you do?
Okay.
This patient, so she has gestational diabetes, but doesn't mean that she's continuing to have the diabetes afterward, right? There are risks, I agree with you, there are risks that they develop diabetes type 2 after pregnancy. They're very high risk, but however, we don't know till we test her for it. So right now we stop the insulin and order glucose tolerance test at postpartum visit.
Really?
You stop the insulin right away, right after delivery?
Yeah, she had it 10 months ago.
Oh, I thought you said 10 minutes.
Just 10 minutes.
Yeah.
Oh, no, sorry, 10 minutes. Yeah, 10 minutes. Yeah, we stop insulin in 10 minutes. Sorry, 10 minutes, yeah.
So
Yeah,
right after birth, you stop insulin?
Yeah, you stop insulin and you give her, glucose tolerance test. We see if she's continuing the same thing. We see what we react according to the glucose tolerance test. If she's still hyperglycemic after the glucose tolerance test, the same guidelines for the glucose.
But my question is, within 10 minutes, her sugars are going to be regular and normal? I mean, a little...
Yeah, so we test for the we do glucose tolerance test, and then we see it. It doesn't take like, it takes a few seconds to do the glucose. Okay, and it would take an hour probably and there's 2 hours test, there's 3 hours. So we test her, we see how is she doing right now. If the glucose is high, then we react to it. If not, then we don't want to give her too much insulin because she's at risk of hypoglycemia too.
So there's no tapering of the insulin decreasing, you just abruptly stop it.
Yeah, it's not like a steroid or something. It's a natural hormone. It's supposed to be increased in a normal way. But just when she's pregnant, there's the HCl, human placental lactogen, that increases insulin resistance. So after delivery, we stop it and discontinue all anti-glycemic after delivery. And the patient with gestational diabetes screened after pregnancy with a 2-hour glucose tolerance test to see if she developed type 2 diabetes or not. Okay, that's the main difference. Okay.
That's something new I learned.
Yeah, it's life, we learn. Yeah. So this is sliding scale. When do we use that?
Not in this lady, I guess.
Yeah. So we do that in the hospital setting because it needs control. Like sliding scale, that's mean it's a very terrible way of controlling blood sugar. Like when it's high, they give it insulin. When it's low, they stop it. Actually, so they react to the insulin. While the proper management for glucose is that we give them glucose before they have we give them insulin before they have hyperglycemia. But this sliding scale is a terrible way of managing. Like if there's a high glucose, we give them sliding scale. We give them like a couple of units for the hyperglycemia. So this one only in hospital settings we use that. Okay. Yeah, so that's the idea of this question. So, and usually we test the mom in 6 to 12 weeks after delivery. We test her for oral glucose tolerance test for this female who are on gestation diabetes. Okay. So this case, so this patient was a 55-year-old man who reports 4 hospital admissions. He's 55. Reports 4 hospital admissions for pneumonia in the past 18 months, sorry. So he's ex-smoker with a 10-pack year smoking history. You see, numbers are important. 10-pack year smoking history, physical examination for crackles at the right lung base and scattered bilateral wheezes. So what is the cause of recurrent pneumonia? What do you guys think? This patient, he's a chronic smoker. So he's a chronic smoker and he's having recurrent pneumonia and 4 hospital admission for pneumonia. So whenever they tell you recurrent pneumonia, we think of bronchiectasis. So it is a small mucosal inflammation leading to rupture of superficial blood vessels. Because of his recurrent smoking habits, so he's developed acute bronchitis. Acute bronchitis have increased in the mucosal glands in the bronchial wall and predisposed to recurrent infection, that cause destruction of the blood vessel. So chronic small vessel vasculitis, what is that? This is vaginal granulomatosis. How does that present? Present with chronic rhinosinusitis, that's a very important thing. And they have arthralgia, hemoptysis, and fever. Those are the chronic small vessel vasculitis. This patient didn't have arthralgia and didn't have chronic rhinosinusitis. So those small stuff matter, very important. Increased pulmonary capillary wedge pressure, when do we see that? This in mitral stenosis, congestive heart failure, you have increased capillary wedge pressure. Why? Because of the backflow pressure. Okay. And the patient with congestive heart failure, they have bilateral crackles. Okay, not crackles on the right side. Like this patient, crackles only on the right side. So you see these small little things are important. So that's the difference. Malignant infiltration of the bronchial wall. So the chest radiograph will show malignancy, and they have hemoptysis too. But when you have copious sputum production with recurrent infection, it's highly suggestive of bronchiectasis. So this could be, but then I should have added the copious amount. So your thinking was right, but the thing is that I should have added this one, copious sputum production. Okay, that's what gonna throw you off the malignancy. This is more likely when you see copious sputum production. This is more likely to be bronchiectasis rather than malignancy. Okay, that's the thing. Yeah, and that's about it. So it's a bronchiectasis and causes recurrent pneumonia. So this recurrent infections keep continuing destroying the bronchial walls, causes that issue. Okay, so copious sputum production. This mucosal inflammation with rupture of superficial blood vessels. Okay. Okay.
How old is this woman?
She's 51-year-old woman. Okay. Comes to the office with a bilateral nipple discharge. Bilateral breast exam, no mass, tenderness, or skin changes. Clear yellow discharge expressed from nipple bilaterally. There is no axillary or subclavicular lymphadenopathy. What's best next step? So this patient have bilateral discharge. So this is benign thing. One benign thing, bilateral. And clear yellow, that's the description, is also benign. That's the second thing. The third thing, there's no other abnormalities. No mammogram is okay, ultrasound is okay. No lymph nodes, no masses, no tenderness. So it's very all benign features you have. So collect nipple cytology, that's never the right answer. This has very low sensitivity. It's not even used for breast cancer. It's very low sensitivity and specificity. It's not accurate at all. Thus, vitamin E and soy doesn't cause that discharge, so there's no need to discontinue that. MRI, this for metastatic. If there's a metastasis of cancer and we want to know where it is, and then we do that. Pericutaneous biopsy, if there is a malignancy, if there is a mass on ultrasound. Palpable mass and suspicious ultrasound and mammogram. We do that. Other than that, we just reassure, because it could be caused due by many stuff. Antipsychotic can cause that. Stress can cause breast discharge. Excessive breast nipple stimulation can cause that. Hyperprolactinemia, thyroid disease can cause that. So this is physiologic discharge. This is physiologic galactorrhea, what it's called. The main thing is to know the difference between the physiologic breast discharge and pathologic discharge. And this one is physiologic, okay? So let's do a rapid review of what we did. I'm just gonna ask you quick questions and you let me know what your thoughts, okay? So copious mucus discharge. What is your diagnosis? Copious sputum with 4 episodes of pneumonia. What's the diagnosis?
Bronchiectasis.
So postpartum female, she used to take insulin. What do you do now?
Apparently stop it and do OGTT.
Yeah, at 6 to 12 weeks, just to reassess if she has type 2 diabetes or not. So patient, when do we do PTU? When do we do methimazole in pregnancy?
First trimester PTU and then methimazole.
Yeah, because methimazole first trimester causes teratogenic. PTU in second trimester causes liver toxicity. Okay. And so patient with alcohol withdrawal, how do we manage that?
Lorazepam.
Yeah, short-acting benzodiazepine, which is lorazepam. A 10-year-old child with recurrent lung infection with constipation, what is diagnosis?
Cystic fibrosis.
Chest X-ray shows nodular opacities in both lungs, including subpleural opacities in the right.
IV. With IV drug use history?
Yeah.
So then infective endocarditis.
Yeah, we do it. What's complication of TERP?
Say that again?
What's complication of TERP, which is transurethral resection of the prostate?
Well, most common is retrograde ejaculation.
Excellent. Punctate hemorrhage on the cervix, what is that?
Trichomonas, treated with metro.
No. Sandy eyes.
Sjogren's.
Sjogren's.
Excellent. We did around like 15 questions with everything. Wow, that's amazing. Okay, yeah, so that's good for now.